السلام عليكم طلبتنا الأعزاء. Today we will discuss disorders of the stomach, diseases or pathology of the stomach. To start with, you should understand the histological and anatomical points. Histologically, the stomach is made or lined by the mucus secreting glands in the cardia and fundus, mainly also the antrum and pylorus are also lined by mucus secreting gland, whereas the acid secreting glands or gastric pits are mainly distributed throughout the body of the stomach, gastric pits containing foveolar cells secreting acid and pepsinogen and pepsin. This distribution is to protect the upper esophagus and lower duodenum from the harsh effect of acid, and to prevent digestion of the esophageal and duodenal mucosa by the acid secretion from the stomach. So mainly the acid secretion is concentrated in the body mainly, whereas the upper part and the lowermost part of the stomach, the fundus, cardia, and antrum and pylorus, are mucus secreting mainly, lining mucosa mainly. Again, for layers: mucosa, submucosa, muscularis, and serosa. This is the esophagogastric junction or squamo-columnar junction. This is the upper esophageal lining mucosa at the junction, and here the start of gastric mucosa, acini, mucin secreting, and mainly with the other four layers. So this is the esophagogastric junction or squamo-columnar junction at the gastric inlet. This is the lining epithelium of the body of the stomach or gastric or corpora. A lot of acid secreting acini or gastric pits. Secreting HCl from the chief cells and pepsin from parietal cells. This is you identify this thick layer of mucin secretion and the gastric pylorus or pyloric sphincter. To prevent the harsh effect of the acid from digestion, or to prevent digestion of duodenal mucosa. So this mucin will neutralize the acid secretion or acid secreted by the gastric body. So mainly in the pyloric area, there is a lot of thickened mucus secreting glands to neutralize acidity. The acid protection, the mucosa of the stomach is exposed to high acidic pH or to acidic pH. due to excess secretion from of the acid from the gastric body, from the parietal cells. So there are normal physiological mechanisms, many physiological mechanisms or protective mechanisms to counteract the acid digestion for the mucosa. Any disturbance of these factors or of these protective mechanism will result in ulceration, erosion, or loss of mucosal surface. Mucus that is secreted by the mucin secreting glands and the as I say previously, and the cardia and the fundus and pylorus and antrum, and that is in the proximal and distal part of the stomach mainly. This mucus will neutralize acidity because of its alkaline nature. Mucus is a protective physiological agent that is contained also bicarbonate. Bicarbonate ion is also neutralize the acidity. Epithelial barrier that is normal intact mucosa or normal intact epithelial cells are a barrier to prevent the acid digestion. Intact blood flow, normal nourishment, normal oxygen supply are protective also. In addition to adequate prostaglandin E and I secretion, prostaglandin will encourage all of these upper factors, encourage bicarbonate, mucus secretion, encourage good and perfect blood flow, and so on. So these are the protective mechanisms or protective barrier to prevent acid digestion or acid secretion of the epithelial surface. Normal epithelial turnover and normal epithelial regeneration and reparative capacity is also important. To start with any organ, we will discuss earlier the congenital anomalies of this organ. In the stomach, diaphragmatic hernia, pyloric stenosis or hypertrophic pyloric stenosis, and pancreatic heterotopia. Diaphragmatic hernia, that is different from, we will discuss it later, that is different from hiatal hernia. Pyloric stenosis or hypertrophic pyloric stenosis, and pancreatic heterotopia, ectopic pancreatic tissue within the gastric mucosa, or the reverse, or ectopic gastric tissue within the pancreatic parenchyma. Normal pancreatic islets within the stomach, or normal mucosal islets or within the pancreatic parenchyma. Diaphragmatic hernia. This is different from hiatal hernia. It is resulting from abnormality in the development of diaphragm and utero during embryonic life, with severe protrusion of the abdominal organ into the chest cavity, including the intestine, the stomach, even the kidney, and so on. It is associated with high mortality rates unless it is corrected surgically. There is incomplete diaphragmatic formation or development. The abdominal organ will be protruded or bulged into the chest with obstruction or pressure on the heart, lung, with resultant pulmonary hypoplasia atrophy of the lungs, pulmonary hypoplasia or underdeveloped lungs, surfactant deficiency, that is important for alveolar dilatation, and pulmonary hypertension. Pulmonary hypertension increase blood pressure through the pulmonary circulation. And also arrhythmias. These are related to physical obstruction or pressure on the heart by the bulged or protruded organs from the abdomen into the chest. Diaphragmatic hernia. It is related to partial or total loss of a region of diaphragm. So the abdominal viscera will herniate from the abdomen into the chest or into the thorax, and these including the stomach, including the bowel, small bowel, and kidney, left kidney, and perinephric fat. So air and bowel loops are seen within the chest. There is no barrier, no diaphragm to prevent this protrusion or to prevent this herniation. So it is different from hiatal hernia is in that the defect in hiatal hernia involving the hiatal orifice around the esophagus. So it is not involved here. It is involved it is more severe, in which region or total absence of the diaphragm with resultant bulging of bowel loops, stomach, kidney, and perinephric fat. Again, the hernial sac or hernial wall is composed of peritoneum, and pleura together. Another congenital anomaly is hypertrophic pyloric stenosis. Hypertrophic pyloric stenosis. Hypertrophy means muscle hypertrophy and hyperplasia. Pyloric mean in the pyloric sphincter. Stenosis mean narrowing or stricture. The pathology here, there is constriction of the pylorus due to pyloric sphincter hypertrophy. Pyloric sphincter hypertrophy. This will result in gastric outflow obstruction. So there will be narrowing of the gastric outlet. It is autosomal dominant and multifactorial, usually affecting firstborn male with higher incidence in male than in female, 3 to 4 male to female incidence. Usually the parents, another risk factors is parent have the same lesion, the same anomaly, hypertrophic pyloric stenosis, and exposure to macrolide material. Hypertrophic pyloric stenosis. This is the esophagus, stomach, and the thickened pyloric outlet or thickened pyloric sphincter. Muscle wall is thickened, hypertrophied, and felt by physical examination of the patient. The presentation is characteristic for this patient, in which there is projectile non-bilous vomiting at birth or soon after birth. Because of the obstruction here, there is no bile comes into the content of the stomach, and the vomitus is projectile containing no bile because of the pyloric obstruction. So dehydration, malnourishment, and acid-base imbalance are complications of this congenital anomaly. Microscopically, under the microscope, we identify hypertrophied and hyperplastic muscularis propria in the pyloric region or in the pyloric sphincter. The muscle of the pyloric sphincter is hypertrophied and hyperplastic abnormally. The signs and symptoms for this patient again is characteristic projectile non-bilious vomiting soon after birth. Soon after birth or at birth. Visible peristalsis. The peristalsis is visible, can be observed, can be seen by naked eye and the abdomen, and also an olive or abdominal olive sensation or palpation can be palpated with physical examination of the patient. Generally, the patient is dehydrated and undernourished due to repeated vomiting and gastric outlet obstruction. Again, this is an X-ray, showed the distended stomach, this stomach from here to there, distended with gases and due to obstruction of the outflow. So the stomach is distended and there is minimal intestinal gases. The correction or surgical correction is necessary to reduce the complication is by pyloromyotomy. Pyloromyotomy, that is dissection of the muscles, hypertrophied muscle of the pylorus. Make incision or make an incision or to dilate the hypertrophied or constricted pyloric segment. Pyloromyotomy. Make an incision to dilate at the pyloric hypertrophied muscle wall to release the constriction and to dilate the sphincter. The another congenital anomaly is, we call it pancreatic heterotopia, or that is normal ectopic pancreatic tissue seen within the gastric mucosa, or the reverse, ectopic gastric inlet or ectopic or gastric heterotopia within the pancreatic tissue. These are normal in nature, but they are heterotopic, that is normal tissue in an ectopic position, in an ectopic site. Presence of gastric mucosa within the pancreas will result in acid secretion, peptic ulceration, and presence of pancreatic tissue within the gastric epithelium will result in secretion of exocrine and endocrine secretory material and all of the consequences, even tumor formation from these normal ectopic epithelial tissue. Inflammation of the gastric mucosa is called gastritis. Gastritis, inflammation of the gastric lining mucosa. It may be as a short episode, or maybe episodes of, or maybe of long duration. It can be acute and can be chronic. The types: acute gastritis and chronic gastritis. Usually, acute gastritis is associated with bleeding, erosion, neutrophil infiltration. Or it can be asymptomatic without symptoms. or sometimes it is associated with nausea, vomiting, epigastric pain, and bleeding, that is upper GIT bleeding, hematemesis, and melena. Neutrophil infiltration is a feature of acute gastritis and active gastritis. Erosion is also a feature of acute gastritis with purulent exudate. So bleeding into the mucosa, hemorrhage, erosion, and neutrophil infiltration are features of acute gastritis. Erosion, hemorrhage, and neutrophils. This is the lining mucosa of the stomach seen with diffused small pinpoint spots of hemorrhages or petechial hemorrhages, mucosal hemorrhages within the mucosa with superficial neutrophilic exudate above the mucosa. Erosion means loss of the superficial epithelium without deep ulceration, hemorrhage, and neutrophils infiltration. Acute gastritis. Whereas gastropathy, this is a term indicate cell injury. There is cell injury, damage to the cells, and reparative process, repair are present without active inflammation. So inflammatory cells, neutrophils are rare or absent. It is caused by non-steroidal anti-inflammatory, alcohol, bile, or stress. Gastropathy is cell injury without active inflammation. Cell injury and repair are present without inflammatory cell infiltration. The pathogenesis of gastritis. As we say in the start, there is a balance between the protective mechanism and the acid secretion. The protective mechanism are the mucus, bicarbonate secretion, intact epithelial barrier or epithelial cells, prostaglandin, and adequate mucosal blood flow. The strongly acidic gastric lumen can result in digestion of this mucosa, gastric mucosa, when there is imbalance or disturbance of one of these protective mechanisms. The protective mechanisms are mucin secretion by the foveolar cells and the gastric proximal part and distal part, cardia, fundus, pylorus, and body. Bicarbonate secretion, which is content of mucin, bicarbonate secretion into the mucus, which is protective or form a lubricant layer on the surface epithelium. Rich or adequate mucosal blood flow, adequate blood flow. So in cases of inadequate blood flow or impaired blood flow, like in low hypoxemia, like in high altitude or chronic smoker, this mucosal blood flow will be affected. The blood supply or blood flow will be inadequate to the mucosa, with the resultant decreased epithelial regeneration and repair. Intact epithelial regeneration and reparative process and reparative capacity of the epithelium. This is associated with good nourishment, with good adequate blood supply, and so on. Prostaglandin synthesis. Prostaglandin will encourage all of the above mechanisms, encourage mucin, bicarbonate, encourage good blood flow supply, and it is important secreted by the gastric epithelial cells and neuroendocrine cells. The causes for this imbalance, for this imbalance or digestion of the mucosa, the non-steroidal anti-inflammatory drug, for example, non-steroidal anti-inflammatory drug will inhibit the synthesis of prostaglandin, inhibit the cyclooxygenase dependent prostaglandin synthesis. And so again, the prostaglandin will stimulate all of the defense mechanisms, mucus bicarbonate and blood or intact mucosal blood flow. So non-steroidal anti-inflammatory drugs will prevent or impair the synthesis of prostaglandin. So inhibition or this will impair the defense mechanisms, intact defense mechanisms, and result in ulcer formation, ulceration, bleeding, and digestion of the surface epithelium. In patient with uremia, there is a lot of or increase in the level of ammonium ion that will and also in H. pylori infection, these two mechanisms will neutralize the acidity in which there is inhibition of bicarbonate transport by the ammonium ion. A lot of ammonium will be secreted will be seen in uremia, and also will be present in patient with H. pylori infection that will inhibit the bicarbonate transport and in neutralization of acidity and inhibit neutralization of acid. Reduced mucin and bicarbonate secretion in elderly people and patients with advanced age. When the patient with increased age or when the patient becomes elderly or becomes in patient with advanced age, there will be decreased the efficiency of the secretory mechanisms or secretory function of many secretory organs in the body. From them, there will be reduced mucin and reduced bicarbonate secretion in these elderly patients. So the mucosa, there will be thinning or loss of the mucin or mucus layer on the surface of the epithelium. And result in acid digestion. Hypoxemia or low oxygen level, especially in patient with high altitude or anemic patient or patient who smoke, and those who are chronic smoker, all of them will have low oxygen supply. This will result in low blood flow and impaired or defective epithelial cell regeneration and reparative capacity. Certain chemicals, when ingested, like acid, base, they are direct toxic or directly injure the epithelial cells and stromal cells, with result in epithelial cell loss and stromal cell loss and acid digestion. Also, alcohol has direct effect and also impair with oxygenation and impair with also non-steroidal anti-inflammatory drug. They are inhibit the prostaglandin synthesis or cyclooxygenase dependent prostaglandin synthesis with associated mucosal loss and mucosal acid digestion. Radiation also result in damage to the epithelium. Also, chemotherapy. Chemotherapy will inhibit the synthesis of DNA and cell regeneration and mitosis. Both acute gastritis and gastropathy may be asymptomatic or may be associated with symptoms, most commonly epigastric pain, nausea, vomiting, and in severe cases, there is mucosal erosion and bleeding, which is upper GIT bleeding, hematemesis, that is bloody vomitus, and melena, that is black tarry stool due to acid digestion or of blood, acid digestion of blood, that is blood is exposed to the gastric acidity and will be digested and result in this black tarry color of stool. So melena indicate upper gastrointestinal bleeding, that is bleeding from esophageal varices, bleeding from esophageal cancer, bleeding from gastric cancer, bleeding from peptic ulceration, or bleeding from severe acute gastritis or erosive gastritis, and so on. Any cause of blood or bleeding in the upper gastrointestinal tract, even in the most commonly peptic ulceration in the duodenum, in the stomach, and so on. Morphologically, there is hyperemia, edema, and vascular congestion, as in the previous picture seen. This is hyperemia, erosion, pinpoint spotty hemorrhages throughout the gastric mucosa or throughout the gastric wall without ulceration, erosion, superficial sloughing. So hyperemia, edema, and vascular congestion. The absence of inflammatory cell indicate gastropathy, whereas the presence of neutrophil, especially above the basement membrane, indicate active inflammation, active gastritis, or acute gastritis. Presence of the neutrophil indicate activity. Absence of the inflammatory cells with the presence of cell damage and repair indicate gastropathy. In severe cases of active inflammation result in bleeding. Bleeding is resultant from erosion or of the blood vessels in the superficial epithelium and the lamina propria, called acute erosive hemorrhagic gastritis. Acute erosive hemorrhagic gastritis caused by any cause previously mentioned: non-steroidal anti-inflammatory drug, H. pylori, smoking, alcohol, and so on. Radiation, chemotherapy. Stress-related gastritis. These are special entities or special types of gastritis resultant from extreme or excessive physiological and trauma and other causes of trauma to the body in response to this trauma, like severe trauma, severe shock, sepsis, extensive burn, intracranial bleeding or intracranial disease, major surgery, severe psychological stress. These patients develop gastric lesions within few days in a response to systemic stress or systemic extreme stress, like in severe trauma, accident, or shock, septic shock, hemorrhagic shock, hypovolemic shock, sepsis. This is called stress ulcer. There will be diminished blood supply to the mucosa of the stomach as a result or from these types of stress or trauma. Extensive burn. It is in case of extensive burn, it is called curling ulcer. Curling ulcer is an acute gastric ulceration or acute gastritis or acute erosive gastritis resulting from a patient with extensive burn. A patient with intracranial disease like intracranial hemorrhage, intracranial transient ischemic attack or ischemia. In these patients, they may develop an acute erosive gastritis or gastric ulcer. It is called Cushing ulcers. Cushing ulcers are gastric erosions or gastric or acute gastritis, acute erosive gastritis, complicated in a patient with intracranial disease, intracranial lesion, recent intracranial lesion, or in a patient with major surgery, exposed to a major surgery, or severe psychological stress, gastric lesions or stress ulcers in the stomach may result or may develop within few days. These stress ulcers or stress gastritis is result from local ischemia to the gastric epithelium as a result of systemic hypotension and splanchnic vasoconstriction induced by stress. So in patient, for example, with intracranial bleeding, intracranial ischemia or hemorrhage, there will be vasoconstriction as a protective mechanism. There will be diminished blood flow to the internal viscera, and there will be the body try to supply the vital organ to save life and vital centers. So there will be splanchnic vasoconstriction, diminished or vasoconstriction of the blood vessels supplying the internal viscera, including the stomach. This will result in stress ulcer or acute erosive gastritis to the gastric as a result of local ischemia and generalized hypotension in response to this systemic stress or systemic major surgery or burn or intracranial bleeding. Also, there will be increased as a result of the generalized mechanism of vasoconstriction. There will be there will be increased secretion of vasoconstrictor endothelin 1. Endothelin 1 by the blood vessel or by the endothelial cells or by the inflammatory cells in the area. With the resultant this will encourage local ischemia and decrease blood supply to the mucosal surface of the stomach. Excessive stimulation of the vagal nuclei. Again, this is associated with in patient with intracranial disease. Excessive stimulation, edema, due to trauma, due to bleeding in the brain. This will result in stimulation of the vagal nuclei. Stimulation of the vagal nuclei centrally in the brain and with excess. This will result that, as you know, the stomach is supplied by the vagal nerve. One of the nerve supply of the stomach is from the vagal nerve. So excessive stimulation of this nuclei in the brain will result in increased acid secretion, and a lot of acid will be secreted with ulcer, with resultant acid digestion and erosion. Systemic acidosis associated with systemic shock, hypovolemic shock, hemorrhagic septic shock, and so on. This will result in lowering or drop in the mucosal cell pH, again with the resultant of damage of these cells as a result of acid digestion. This is a picture showed acute esophagitis with associated acute gastritis. This is called acute erosive esophagitis and acute erosive gastritis. The same mechanism can be associated with can causing the same lesion and erosion in the esophagus and stomach. Acute gastritis, hyperemia, edema, superficial bleeding that may be associated with hematemesis and melena, and epigastric pain. The another type of gastritis is chronic gastritis. Or it is called atrophic gastritis or gastric atrophy in severe cases. Here in the chronic type, in the chronic gastritis, there is a presence. In the acute type, we say that is neutrophils are characteristic of acute gastritis. Whereas in chronic gastritis, chronic inflammatory cells infiltrating the mucosa, infiltrating the lamina propria, are characteristic of chronic process or chronic inflammation, chronic gastritis. So we should identify plasma cells, lymphocytes, that they are mononuclear cells, with associated epithelial metaplasia. Metaplasia is the reversible change of one type of epithelium into another in response to stress. Mucosal atrophy is an advanced stage, is a late stage of repeated attacks of chronic gastritis with resultant loss of glands. So the glands are atrophied, or there will be decrease in the number of gastric glands, called mucosal atrophy. With that is result from glandular loss, and the stroma seen widened and expanded due to loss of the glands, usually in the absence of erosion. Erosion is a sign or feature of acute gastritis rather than chronic gastritis. So chronic mononuclear inflammatory cells, epithelial metaplasia, gastric atrophy, glandular loss, and absence of erosion. Intestinal metaplasia means presence of goblet cell or intestinal goblet cells. Two main types of chronic gastritis. Two main types. Infectious, autoimmune. There are infectious and autoimmune, mainly infectious forming about 80% and autoimmune form up to 10% of patients that are negative for infectious agents. Another less common types including biliary gastritis, type of chronic gastritis, radiation-induced, chemotherapy-induced, and so on, but they are rare. So the main two types are infectious, and the main cause is H. pylori infection and autoimmune process or autoimmune gastritis forming up to 10% only. H. pylori gastritis, or what we call it H. pylori associated chronic gastritis, H. pylori associated chronic gastritis. H. pylori is very common, especially in poor sanitation or in low socioeconomic status, in people with low hygiene and in and poverty, rural areas. So they form up to 80% of cases of chronic gastritis. They are seen within the gland. They are seen within the gland. They are extracellular. They are not entered the cells. They are seen within the mucus layer, or within the glandular lumina, within the mucus layer or within the glandular lumina in the superficial mucus layer. They are S-shaped or comma-shaped or curved or spiral, as you want, gram-negative cocobacilli. More commonly seen inhabitant the antrum, gastric antrum and body, gastric antrum and body. Within the gland or within the surface epithelium, spiral or small cocobacilli, curved, comma-shaped, and so on. They are seen or they are affecting patients with, as we say, with low sanitation, low and poverty, and those in rural areas, and in patients with low socioeconomic status. Also affecting patients with advancing age, increased with age, the colonization again to the mucosa. They are their colonization impair healing and impair regeneration, and result in chronic gastritis. Also role of metabolic cellular alteration due to infection, bacterial toxins, and host inflammatory responses. This type of bacteria has response to antimicrobials, so they are good response to type of antibiotic. Also, this H. pylori bacilli or Helicobacter bacilli are implicated in most of gastric lesions, started from chronic gastritis, acute gastritis, gastric ulceration or peptic ulceration, gastric carcinoma, gastric lymphoma. All of these cases, H. pylori can be isolated from these lesions, even in gastric cancer, chronic gastritis with metaplasia, with intestinal metaplasia, gastric atrophy, lymphoma, and even gastric adenocarcinoma. They are present in almost all cases of gastric and duodenal ulceration. They are inhabitant, as I say, antrum and body, inhabiting the antrum and body. Antrum is mainly, and so it is mainly associated with antral gastritis. Biopsy should be taken from the antrum in suspicion of H. pylori gastritis, antral gastritis. So there will be increased acid secretion and peptic ulcer digestion in the stomach and duodenum. This type of bacteria will result in excess secretion of causing ammonium ion secretion, or this will result in rebound acid secretion as a compensatory mechanism to counteract the ammonium secretion or ammonium neutralization, ammonium secretion by the bacteria, so by H. pylori bacteria. So there will be rebound acid secretion. There will be excess acid secretion, stimulation of acid secretion to neutralize ammonium, but there will be a lot of acid secreted to result in peptic ulcers and excess acid in the stomach and the duodenum. Destruction of the parietal cells in the body and fundus with reduced acid secretion and hypergastrinemia. Reduced acid secretion due to destruction of the parietal cells in the body and fundus, and hypergastrinemia. Hypergastrinemia as a result of when there will be destruction of these cells in the body and fundus that are secreting acid. So there will be excess in secretion of gastrin hormone by the G cells that are neuroendocrine cells, and hypergastrinemia with excessive gastritis of the body and fundus that may result in intestinal metaplasia and risk of cancer. Excessive gastritis in the body and fundus which may result in intestinal metaplasia and risk of cancer. In the early stages, there will be lymphocyte and plasma cells infiltration in the lamina propria. In the early stages, there will be lymphocytes and plasma cell infiltrating the lamina propria. Chronic inflammatory cells infiltrating the upper third. This is called, in earlier stages, called chronic superficial gastritis. Chronic superficial gastritis. In severe cases, there will be the inflammatory cells with the lymphoid aggregate infiltrating the whole thickness, all the mucosal thickness of all the mucosal thickness will be infiltrated by inflammatory cells with the association of lymphoid aggregate or lymphoid follicles within the submucosa. Another features or additional features of an chronic H. pylori associated gastritis is activity. Activity is indicated or demonstrated by neutrophil infiltration. Active gastritis. Presence of neutrophil indicate active gastritis. Regenerative changes or reparative process. There will be enlarged hyperchromatic cells with mitotic activity within the mucosa. So, presence of inflammatory cells, neutrophils, and presence of enlarged hyperchromatic cells with increased mitotic activity indicate regeneration. Metaplasia is goblet intestinal cells, replacement by goblet metaplastic cells. Goblet intestinal cells present within the gland. Glandular atrophy or glandular loss, there will be decrease in the number of the glandular acini or gastric acini or gastric gland, decrease in the number due to repeated damage and repeated loss. H. pylori bacilli are found on the superficial epithelium on the surface, within the mucus layer, or within the glandular lumina, not intracellular. Dysplastic changes, presence of dysplasia can be detected in chronic long-standing H. pylori associated gastritis with intestinal metaplasia indicated by cytological atypia from high NC ratio, hyperchromasia, increased mitotic activity, irregular nuclear membrane, and so on. And in severe cases with intestinal metaplasia can result in gastric intestinal type gastric adenocarcinoma. So because of the preceding intestinal metaplasia, so the resultant gastric carcinoma is intestinal type gastric adenocarcinoma. One of the virulent or one of the effective factors or virulent factors in H. pylori is the cytotoxin associated gene A. Cytotoxin associated gene A is the carcinogenic virulence factor of H. pylori. Normal gastrin level and no hypochlorhydria, no antiparietal cells, no antiparietal cells, anti-intrinsic factor antibodies, those are seen in autoimmune atrophic gastritis, hypochlorhydria, antiparietal atrophic gastritis, hypochlorhydria, antiparietal anti-intrinsic factor antibodies. So these are antibodies, types of antibodies detected in autoimmune atrophic gastritis, autoimmune gastritis. Not seen, no antibodies are detected, or no antibodies, this type of antibodies detected in H. pylori associated gastritis. These are detected only in autoimmune type atrophic gastritis. Antibodies to parietal cells and antibodies to intrinsic factors are with hypochlorhydria or achlorhydria are detected within the serum of patient with autoimmune gastritis. In addition to gastric ulcers, can be seen as complication in patient with H. pylori gastritis. The autoimmune type or autoimmune gastritis, it is a diffused, also called diffused corporal chronic gastritis. Diffused corporal chronic gastritis mean it is affecting the body. Body is mainly affected. Corporal, the body is mainly affected. Whereas in H. pylori, the antrum, it is an antral type gastritis. Diffuse corporal chronic gastritis. This constitutes 10% of chronic gastritis, in which there is damage limited to the body and fundus. Autoimmunity is inherited against the intrinsic factor and against enzymes in the parietal cells that are important to form gastric acid or HCl, result in inhibition of gastric acid secretion, hypochlorhydria, that is decrease in the level of intraluminal level of HCl, decrease in intrinsic factor. Intrinsic factor will due to antibodies, and when the intrinsic factor that is important for B12 absorption, so result in B12 malabsorption and pernicious anemia with associated other autoimmune diseases. Many times autoimmune processes or disorders come in clusters or are familial. Another features of autoimmune gastritis is antibodies to parietal cells and intrinsic factors in the serum, antibodies to parietal cell antibodies and intrinsic factor. So in the serum of the patient with autoimmune gastritis, there is increased level of parietal cells and intrinsic factor antibodies. Decrease in the serum level of pepsinogen 1, decrease in the serum level of pepsinogen 1 due to defective or antibodies to parietal cells or antibodies to enzymes important for formation of acid. So again, the parietal cells are parietal cells secreting pepsinogen, so there will be decrease in the serum pepsinogen 1. Antral endocrine cell hyperplasia, antral endocrine cell hyperplasia. This is to compensate for the decreased level of intraluminal acid. There will be hyperplasia of the endocrine cells to secrete gastrin, to increase the level of gastrin, that is, stimulate acid secretion. But there are no or defective production of HCl, and there's intrinsic factor. There is defective or antibodies to parietal cells. There is parietal cell damage. Also, there is vitamin B12 deficiency due to intrinsic factor antibodies and decrease in the level of intrinsic factor that is important for absorption of vitamin B12. Defective gastric acid secretion result in impaired iron absorption. Acidity or acidic medium is important for the conversion of ferric iron to ferrous. For iron to be absorbed, it's important to convert it into the ferrous state in the presence of acidic media. So iron will stay in the ferric state, in the non-absorbable state, result in impaired iron absorption and iron deficiency anemia. G cell hyperplasia, that are neuroendocrine cells secreting gastrin, result in hypergastrinemia, and also hyperplasia of these cells may result in neuroendocrine cell tumor formation. Tumor formation as a result of chronic attacks of G cell hyperplasia or neuroendocrine cell hyperplasia. So there will be increase in the risk of neuroendocrine tumor and increase in the risk of gastric adenocarcinoma also. Morphologically or microscopically, there is damage to the oxyantic acid-producing cells. Acid-producing cells in the gastric pits or in the gastric glands, in the body and fundus. Oxyantic acid-producing mucosa in the body and fundus. There will be absence of antral and cardiac damage. That is a feature of H. pylori associated gastritis. The damage here is mainly in the body, so it is called diffuse corporal gastritis, body and fundus, whereas in the H. pylori the damage is mainly antral and cardiac. Diffuse atrophy, that is loss of the decrease in the number of gastric glands, and rugal folds are atrophied. The wall is seen thinned, and even submucosal vessels are seen and exposed. Diffuse atrophy and rugal fold atrophy or disappearance. Lymphocytes and plasma cells and macrophages in the lamina propria. Lymphocytes and plasma cells and macrophages that are mononuclear cells in the lamina propria, not acute cells. Parietal and chief cell loss with intestinal metaplasia. Intestinal metaplasia with parietal and chief cell loss in the body of the stomach with intestinal metaplasia. Chronic gastritis, plasma cells, mononuclear cell infiltration in the lamina propria, that is plasma cells and lymphocytes infiltrating the lamina propria. There will be glandular distortion, and that is what we mean by glandular atrophy. There is widening of the stroma or interstitium and decrease in the number of the glands. Goblet cells or intestinal goblet cells are seen within the glands. So, intestinal metaplasia replacement can be seen in chronic gastritis, H. pylori, or autoimmune associated gastritis, autoimmune gastritis, chronic autoimmune gastritis. This is a summary or overview for both autoimmune and infectious types of chronic gastritis. Chronic gastritis. The etiology in autoimmune is uh, 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 it is immune mediated with familial predisposition. There are antibodies to antibodies to enzymes important for gastric acid secretion in the gastric cells, in the gastric body, whereas the etiology is H. pylori infection. H. pylori infection. The affected area in autoimmune gastritis is the body and fundus, whereas antral gastritis is a feature of H. pylori infection or infectious chronic gastritis. The mechanism behind is hypochlorhydria or achlorhydria due to antibodies to parietal cells, So there will be defective or impaired secretion and production of gastric acid by the gastric glands, with resultant stimulation or neuroendocrine cell hyperplasia or G cell hyperplasia that are secreting gastrin to stimulate excess acid secretion, but without benefit, because there are antibodies against the parietal cells in the serum. So hypergastrinemia to stimulate excess acid secretion that may result in G cell hyperplasia and even neuroendocrine cell tumors. Whereas the mechanism in H. pylori is urease production by H. pylori. Which will neutralize the acidity and secreting excess ammonium and result in gastric ulceration. Clinical presentation in autoimmune gastritis the patient may be asymptomatic until severe symptoms with vitamin B12 deficiency and malabsorption. Whereas in infectious gastritis, H. pylori gastritis, the epigastric pain is the main clinical sign, epigastric pain. Histologically, lymphocyte infiltration and lymphocyte aggregates, histologically lymphocyte aggregate and follicles within the submucosa, whereas in infectious H. pylori, there will be neutrophilic infiltration, indicate activity, and regeneration and repair, indicate activity. Neutrophil indicate as if it is a chronic, but neutrophilic infiltrate indicate active repair and active and regenerative process with repair. The common complication in both types in autoimmune gastritis, pernicious anemia. Pernicious anemia is a common complication as a result of vitamin B12 deficiency. Iron deficiency anemia due to impaired iron absorption, in which the iron remain in the ferric state due to impaired iron acid secretion, no acid medium to convert ferric to ferrous state, which is absorbable. and carcinoid tumor, that is a neuroendocrine tumor resultant from repeated attacks of neuroendocrine or G cell hyperplasia without benefit to compensate for acid secretion. Whereas the complication in H. pylori gastritis is peptic ulceration, repeated peptic ulceration due to acid digestion and disturbance and neutralization and rebound acid secretion after secretion of ammonia by the neutralization of urease production that will neutralize acidity, ammonium, and result in rebound formation of rebound cycles of acid secretion. In addition to the a type of lymphoma within the gastric mucosa called affecting the mucosal associated lymphoid tissue. Lymphoma of this type of the submucosal lymphoid tissue is called mucosal associated or mucosa associated lymphoid tissue lymphoma, that is maltomas. Maltomas, low grade and intermediate grade of lymphoma of the submucosal immune system within the gastric wall. Another associated conditions, as I say, autoimmune diseases like rheumatoid arthritis, SLE, autoimmune hepatitis, autoimmune thyroiditis, diabetes, and so on. Autoimmune diseases are come in clusters, or there is certain family history of autoimmune disorders. Whereas the commonest association with H. pylori is low socioeconomic status. It is common in rural areas and poor communities and poverty. With poverty and bad sanitation. And thank you. This is for this part of the first part of the gastric disorders. In the next lecture, we will discuss the gastric peptic ulceration, gastric tumors, and their details. Please, thank you.